I think this slide will help you to conceptualize what frailty is all about. We see that as one moves from a robust state to the frail state, we see a decrease in resilience, and that's reflected in an inability to maintain homeostasis when subjected to certain stressors like surgery. What does this do? This leads to unfavorable surgical outcomes in the frail patient. The bottom line is that frailty results in vulnerability to health status changes. Now, given these complex interrelationships that we see with frailty, it's no wonder that there's no general consensus as to how to define it. Suffice it to say that there's two main schools of thought. One is the measurement of frailty by the accumulation of unrelated deficits, and this would be represented by the Edmonton score. And the other way to measure frailty is actually via a phenotype, which primarily focuses on underlying functionality and muscle mass and ability to walk. This just shows you kind of the differences between the two major ways of measuring frailty. You see on the biologic-driven frailty, it's primarily focused on muscle strength, walking, and physical activity, whereas the deficit accumulation model looks at basically all the components of the patient, from social vulnerability, living situation, medical conditions, cognition, and functional decline. Be it as it may, no matter how you measure frailty, the bottom line is it's very common in the elderly. When we look at community living elderly, 10% of those people are actually classified as frail, and 40% are pre-frail. Not only that, but frailty increases with age. In addition, it's more common in women, more common in African Americans, and those of lower socioeconomic status. Why are we concerned about frailty in surgery? It's because in multiple types of surgical procedures, what we see is frailty is associated with an increased incidence of complications as well as increased mortality. In addition, frailty is also associated with many geriatric syndromes like delirium, like incontinence. They're also more prone to falling as well as immobility. So here's a frail patient, and look at what happens to this individual. He's 82 years old, he has hypertension and osteoarthritis. He's presenting for a total knee replacement, and he's had a 15-pound weight loss over the last 3 years. Functionally, he seems to be okay. He's able to perform all his ADLs and IADLs. However, he is cachectic and weak, and the medical workup, however, is completely negative. No evidence of major depression, although he does complain of fatigue. He has uneventful surgery. He goes to a subacute rehab facility. He really doesn't make much progress following his surgery. He's unable to care for himself. He ends up going to assisted living, and he dies 6 months later. They think it's probably cardiovascular. Okay, true or false? The poor outcome is related to the patient's underlying comorbidity. How many people say that? Is it unrelated? Right, the patient really doesn't have that much in the way of underlying comorbidities. How about geriatric co-management? Should that have occurred? And when I'm talking about geriatric co-management, we'll talk about that a little more in some of the slides to follow, but this involves more or less bundled care, looking at nutrition, exercise, more individual approaches to medical management. Should that have occurred in this patient? How many people say yes? Okay, that's probably true, as we'll see. How about pre- and post-surgical, more intensive exercise regimens? True or false? Probably true. Okay, the patient is at higher risk for mortality. Yes, all patients who are frail are at higher risk for mortality. What kinds of interventions can we do in patients who are frail to try to improve their surgical outcomes? Well, a lot of these interventions are based on much older studies looking at elderly patients seeking to try to increase their functionality and muscle mass. And what we've seen is definitely exercise does increase function in the elderly. And when you give nutritional supplementation on top of that, that increases the functionality even more. However, nutritional supplementation in and of itself does not necessarily lead to increase in muscle mass or functionality. Now, they've taken this a step further. We're looking at some of these geriatric co-management bundles, looking at cognitive exercise, exercise alone, as well as nutritional supplementation, as well as more individualized medical management, looking at things like better management of the drug regimens that these patients are on. And what you see is, once again, all these things can lead to an improvement in the frailty status. But once again, the most important component of improving frailty or leading to better, lesser frailty scores is exercise. And this came to light even more, and the enthusiasm for exercise has improved much greater with some of the publications of more recent studies. This one is from Spain, where what they did was they looked at these very elderly patients who were hospitalized and just gave very simple exercise interventions, and they found that they were actually able to lead to better functional outcomes in these hospitalized patients who were not necessarily subjected to this deconditioning that you see with hospitalization of the elderly. Okay, so given all of this evidence, believe it or not, there really aren't that many studies that have been done in surgical patients who are frail. And I'd like to just review some of the data in terms of interventions for frailty. First of all, one of the primary things that's been looked at is these geriatric care bundles, which I described previously. Do they work or don't they for improvement of frailty? In a general surgical population, what you see here is in terms of 30-day mortality and postoperative complications, the geriatric care bundle, really we saw no difference in a general surgery population. However, when we looked at functionality and improvement in function, we did see that in a general surgical population, there is improvement postoperatively. You don't necessarily see it right before surgery, but postoperatively, you will see an improvement in function with these geriatric care bundles. However, that doesn't hold for all surgical populations, and you see that when they looked at a mixed surgical population as well as those with solid tumors, you didn't quite see the improvement in functionality with these geriatric care bundles. Okay, the other thought is that many of these patients who have frailty have chronic anemia, and the thinking goes that maybe liberal transfusion regimens may be associated with better outcomes. However, in the one study that I was able to find, looking at this, an improvement in frailty, liberal transfusion regimens are not associated with any increase in functionality. Okay, what about exercise? There's been a lot of work in the orthopedic patients as well as in cardiac surgery patients. And what we see here is with hip replacement, once again, you don't see necessarily an improvement in functionality right before surgery, but if you look at patients down the line postoperatively, you do see an improvement in function. Similarly, with hip fracture patients, cardiac surgery patients, same type of outcomes, better functionality. But the one key, and this summarizes these particular studies, the black circles are those where the interventions did not work, and you can see with transfusion, and in the mixed and solid tumor populations, the geriatric care bundles didn't necessarily work in improving functionality, whereas in general surgery populations, the geriatric care bundle does seem to lead to improvement in functionality, and in orthopedic and cardiac populations, exercise alone does improve functionality. However, I must caution you that there has been no evidence linking this improvement in functionality to necessarily a decrease in complications or mortality. And this is emphasized also in a recent systematic review looking at colorectal surgery patients where they instituted prehab protocols in several of these studies. Once again, they found improvement in function postoperatively, but that didn't necessarily translate to less complications or less mortality. So I think that there needs to be a whole lot more work done in this area, but the evidence is suggestive that you do get improvement on function. The other things that you can do for your frail patients is make sure that you optimize the vitamin D levels, because lower vitamin D levels have been associated with poor physical performance. Also, something else to keep in mind is that patients on ACE inhibitors do see an increase in their exercise capacity and muscle mass. This is a rather prolonged process. As you can see, it takes over 20 weeks for you to see the effect with these drugs, and it's an area of intense investigation right now. So how do we put all of this information together in managing our surgical patients? Here are the guidelines from the American College of Surgeons, and they say that frailty does help to assess and guide decision-making in patients about to undergo a procedure, because you know that it increases risks. In addition, it identifies patients and helps us to identify those that might be where a rehab program may actually help to improve outcome, although once again, we don't have good data on that particular area. It also will help with implementation of team-based care pathways. And once again, these geriatric co-management bundles are very important. We know that they do lead to better functionality postoperatively. And also, the International Panel on the Integration of Frailty into Clinical Practice also says pretty much the same thing. And notice the wording here.